Hi, so hello to whoever's watching this. Welcome to this kind of short presentation, working alongside parents diagnosed with borderline personality disorder. So I guess just to introduce myself for a start, my name is Dan Warrender. I'm a mental health nurse. I am a lecturer in mental health nursing, and I'm a mentalization-based treatment practitioner, and I still work for the NHS with people with the BPD diagnosis. I've done a bit of research and writing around the area of kind of BPD. I'm also part of the Scottish Personality Disorders Network executive group. So that's a little bit about me and probably a little bit about why I'm talking to you about this. There's some kind of contact details for me there as well. Now, I'm going to try and be, I guess, as brief as I can, knowing that I can talk quite a lot about this topic because I'm very passionate about it. And just to bear in mind that this is quite a short introduction, so we will provide further resources for you. A lot of these concepts, there's a lot written about it. There's a lot of different ideas and perspectives. So it's worth bearing that in mind, that this is just a kind of really an overview to get you guys thinking. So what I'm going to do is we're going to think about some of the experiences and symptoms associated with BPD. We will critique the diagnosis. I think that's really useful just in terms of being able to work with people as human beings, as individuals. I think it's really important that we look at that through a critical lens. And we'll relate understandings of BPD to potential experiences for new parents, bearing in mind that every human being is different. Now, I guess a note regarding language in BPD, you'll notice that I've put BPD in inverted commas. Now, that's very deliberate to kind of highlight the controversy and debate around the diagnostic validity, to emphasize that personal autonomy around how people understand their own experiences. All psychiatric diagnosis is quite controversial to a degree, maybe none more so than BPD. I'll give you a bit more background around that later on, but certainly it's something that I've been in the habit of for the last while, is putting BPD in inverted commas. And instead of writing people with BPD, writing people diagnosed with BPD, because there is a lot of debate about whether we should be labeling people as disordered, particularly when a lot of difficulties are understandable given the life experiences that people have been through. So let's get into, I guess, a brief overview, and we'll kind of go into some of this in a little bit more depth. So the etiology, so there's a biopsychosocial understanding of mental health issues. So there's a bit of genetics in there. We're all biological creatures. You know, I mean, a word about genetics and BPD is that the evidence base is limited and inconclusive. There is no specific BPD gene, and the understanding of genetics at the moment is not about susceptibility. So not about you've got these genes and then you're more likely to develop BPD. It's more a case of genetic plasticity. So increased sensitivity towards the environment. And if the environment is weighted towards negative experiences, that might kind of contribute to some symptoms or difficult experiences for people. And I think that's really important to remember, that actually the experiences that people have are the most kind of powerful explanations for what people later go through. So adverse childhood experiences, trauma, difficulties in attachment relationships are quite common in the histories of people with the diagnosis, but people always have a really unique path to developing their difficulties. No two people are the same. There is no one straight line in terms of this happens, then you will be diagnosed with BPD. Epidemiology, so prevalence in general populations of Western countries, 0.7% to 5.9%. I think 0.7% is Norway, 5.9% is the USA. The UK is sitting about kind of 1 to 2%. But I think we need to take these kind of figures with a pinch of salt, given some difficulties in making psychiatric diagnoses, given that some people might have similar difficulties, be undiagnosed. There's a lot to think about there. 70% of people with the diagnosis are female. Now, we don't think that that's kind of necessarily an accurate reflection of the way things are. We think that there might be men that are underdiagnosed or diagnosed with antisocial personality disorder, or men might be more likely to end up in the criminal justice system or in substance use services as well. So it's worth bearing in mind. But there's certainly strong feminist arguments against the diagnosis, that it's kind of pathologizing women who are often kind of survivors of abuse. And there's a high use of healthcare services, and certainly people with a diagnosis are commonly known to kind of present to primary care and secondary care services. So that's a little bit of an overview to get us going. Now, the things that happen to people or don't. Now, like I really want people to kind of remember this, because the experiences that people have had will allow us to make sense of people's behavior in the present, and it helps us make sense of what people are thinking or feeling, and as a result of what they're doing. So BPD is associated with experiences of adversity and neglect. So trauma and adversity, there's a high correlation between childhood sexual abuse and BPD, and people with diagnosis are 13 times more likely to report adverse childhood experiences than non-clinical control groups. Okay. In terms of attachment relationships, I really like this quote from Bateman and Fonagy. Our understanding of others critically depends on whether, as infants, our own mental states were adequately understood by caring, attentive, non-threatening adults. So you've got kind of two things in there in terms of understanding trauma, adversity, and then attachment. And like I'm saying, it's the things that happen to people or the things that don't happen to people. And we suggest that I kind of a deeper understanding of trauma and attachment is essential, I would say, if you're going to be working with people diagnosed with BPD. An understanding of these concepts and what happens to people is really invaluable in terms of a lens of understanding people's behavior, and then being able to respond to that sensitively. So with trauma, potentially people develop a sense of hypervigilance, can have difficulties trusting people. Actually has an impact on brain activity as well. People can have a real sensitivity to particular triggers. They can have attentional bias, and essentially your brain can become kind of wired to seek and respond to threat. The world becomes a very scary place. If people have difficulties in attachment relationships, essentially not being understood, not having their mental states kind of fed back to them, then you can have difficulties mentalizing, so have difficulties understanding ourselves and understand other people, and that can make it very difficult for us in later relationships. And I guess to put that simply, if you've been hurt by people in the world, then you will see the world as a dangerous place. You might do things to protect yourself and have difficulties trusting others. And in terms of attachment, it might be hard to understand other people and social scripts if you yourself have not been understood. So these two things that I would certainly encourage people to get more of an understanding of, they really influence how people understand themselves, others, and the world. And I've got an eye there as the big kind of picture, because I really think a useful way of thinking about it is this is your way of seeing the world. Now imagine that your experiences are a pair of glasses. So imagine that, like, here I am just now, I've had a reasonable kind of childhood that's been supportive, I've been nurtured, I've been valued, I've not had traumatic experiences. Then imagine the opposite, So imagine I put on these glasses and I've been through some horrendous trauma. People that should have cared for me have hurt me. I've not been understood, so I'm having difficulty understanding others. And now I'm going out into the world. So the difference between me walking into a room of people I don't know like this and being reasonably comfortable that people are going to be okay, people are going to be respectful of me, people can be trusted, or wearing these glasses and I go into a room and I think that, like, people can't be trusted, people are going to hurt me. You can quickly see how people have very different relationships with the world around them that are adaptive, adapt to our environments in terms of trying to increase our chances of survival and making it through. So keep in mind that way of seeing the world is incredibly important. Now, symptoms and experiences, again, I've put symptoms in inverted commas, deliberately try to kind of push people into thinking a little bit differently. Now, onset of symptoms with the BPD diagnosis tends to be by early adolescence. Now, symptoms, and this is the reason they're in inverted commas, is they're often understandable given life experiences. Yeah. So we can potentially move away from a kind of medicalized understanding of this being illness or a disorder, and actually adaptive responses to things that have happened to people. And the power threat meaning framework that people might have heard of, it's a kind of sort of new framework model and proposed as an alternative to psychiatric diagnosis that reframes these symptoms as threat responses. And what that's doing is it's actually trying to tie the things that people think, feel, and do back to their kind of causes. It sort of links them up with the reasons that people think, feel, and behave in particular ways. So it's helpful to think of symptoms as things that people feel and things that they do. And like I said, things that often make sense given what people have experienced in their lives. Now, there's general agreement in the symptoms of severe emotional dysregulation. So real difficulty kind of controlling and regulating emotional states that can be really, really overwhelming. A strong impulsivity, so there's not necessarily a thought before action. You know what I mean? People can act really impulsively, really quickly, not necessarily think about the consequences. And there's a social interpersonal dysfunction. So there's a difficulty kind of navigating social scripts, understanding self, understanding others. And obviously that makes life in social relationships very, very difficult. And certainly people have described that as a kind of like a claustrophobia in your own skin. You know what I mean? Imagine you've been through some difficult stuff in your life, find it difficult to control emotions, find it difficult to control your impulses, and find it difficult to kind of interact with other human beings as well. And that can be really, really tough for people. People might experience frequent crisis. The diagnosis is associated with crisis when people feel overwhelmed, feel like they can't cope, and often will seek help or sometimes try and manage that emotional distress in ways that might not always be helpful for them. Now, suicide completion rates range between 3.8% and 10%. There's thoughts that those rates might actually be better now. I think there's better understandings and there tends to be better treatments than they were. But it is a diagnosis that is associated with people that might self-harm and people that might attempt suicide. So it's something that really raises anxiety in health professionals. And I think we can certainly become overwhelmed as professionals and kind of almost become immersed in our own distress at times. And we need to really remember what's going on for that person that's contributing to these really, really difficult feelings that are leading people to think that they want to die or they need to kind of harm themselves to get through it. Importantly, most people will improve over time. And like, I'll really try and emphasize that we need to emphasize hope for people. Because I think when people feel that claustrophobia in their own skin, they feel completely disconnected from the rest of society. They feel in a really, really dark place. And it's important when people don't have that hope that we can kind of help them carry that. We can carry that hope for them. Okay, I'm deliberately talking fast to make sure I get through everything for you in a reasonable amount of time. Now, to critique some of the diagnosis, which I think is really useful. I think if we're very diagnosis focused, I think that can push us away from being person-centered. And I think sometimes a focus on labels, it does kind of remove us from that human connection, which is the most valuable thing that we can offer anyone. So there's no objective test for any psychiatric diagnosis. So all of these diagnoses are subjectively applied by people. And I'm sure we've all seen that, what the human factors that go in to different opinions that can lead to maybe the same person receiving different diagnoses or different perspectives by different professionals. So we need to keep that in mind for a start. You know what I mean? That it's quite a woolly thing. You know what I mean? There's no blood test for getting a particular psychiatric diagnosis. This is something that we see sort of a person's behavior, we talk to them, and then we kind of make a judgment on it. So it's not an objective test. The way that diagnoses are developed, you know what I mean, it's a really kind of contentious thing as well. I don't want to go into too much depth of that, but there's a lot written about that. There's a book by James Davies called Cracked, where he talks about the DSM-3 being developed, and it's described as kind of consensus rather than science. And it's described as a group of psychiatrists essentially trying to kind of more akin to them deciding what kind of takeaway they're going to order rather than a kind of clearly scientific process. You know what I mean? It's about consensus, about what do you think is depression, what do I think is depression, and essentially a bit of debate and kind of going back and forth. Now that was certainly from 1980. I think it's certainly moved on from there, but the same principle remains, that it is by consensus rather than an objective test. Now, the problems with BPD in particular, so if we look at the DSM criteria, so the American kind of diagnostic classification, so there's 5 or more of 9 criteria needed to meet the diagnosis, but there's no core features. So it means that people don't necessarily need 1, 2, and 3. They can have any 5 out of that 9. So it means people can have criteria 1, 2, 3, 4, 5. They can have 9, 8, 7, 6, 5. They could have 2, 4, 6, 8, 9. They could have all 9. And someone's done an algorithm and said essentially with the same diagnosis, you can have up to 256 possible distinct presentations. So that's 256 people with slightly different variations and symptoms, but they all get the same diagnosis. So that starts to make us think, you know what I mean, well, how accurate a label, how useful a label is this? On top of that, we've got a high prevalence of comorbidities, and NICE say that an individual with pure BPD, so with no comorbidity, with no different diagnosis, is really rare. There's an overlap with autistic spectrum conditions, shared characteristics with complex PTSD, and really, when you look at the comorbidities, you name it, and there's a comorbidity associated with BPD, and it has been described as one of those kind of catch-all diagnoses where such a wide group of people can end up fitting this diagnosis. So there's a potential for a highly heterogeneous group of patients with the same diagnosis, so lots of different people with the same label. And again, this is just to emphasize that, so the person that you work with is absolutely unique. So the diagnosis might be useful to a degree to get people into the right treatment, but I think once you are engaged with them, I would largely kind of let go of some of that BPD stuff and just understand the person in terms of their life context and what's went on for them. A little bit about the diagnosis, just because it is kind of changing just now. Now, the DSM-5 that came out in 2013 has retained borderline personality disorder. Quickly to talk about the borderline thing, because I think that's still misunderstood by a lot of people. The term borderline came from, I think, Alfred Stern in 1938. It was patients in between what he described as neurosis, like anxiety, depression, and psychosis. So that's where the term borderline came from. It's not an almost personality disorder. I think that's what people often kind of misunderstand it as. And the term borderline, it's not particularly meaningful in terms of a descriptive kind of understanding of what it is. The ICD-10 has had emotionally unstable personality disorder, borderline type, BPD and EUPD. The same thing. It's the same thing. And like with 2 different labels, that's not always helpful for people either. Not helpful for clinicians, that I still hear it misunderstood by practitioners and clinicians, professionals, and misunderstood by patients as well as a result of that. Now, the ICD-11 that is going to be coming in, they've actually removed categories of personality disorder. There'll be a spectrum of mild, moderate, severe. but there will still be kept kind of domain traits, so ways of describing particular patterns of behavior, and borderline type traits will be in there as well. It's a long-winded way of saying that BPD is going to stay in some form for the time being, despite a lot of controversy and a lot of arguments that say that we should do away with it. So just checking notes, making sure I'm not missing anything to say yet. No, it's fine. Now, trauma-informed care, incredibly important. So we've emphasised what people go through is really important in terms of understanding their behaviour in the present. These resources that I'll show you over this slide and the next are from Beacon House. They've got lots of free, accessible, really useful resources, really important in terms of kind of understanding trauma. So looking through a trauma lens, okay, and looking through a trauma lens is just that, keeping in mind what might people have experienced in the past, you know what I mean? What have people been through in the past that will help us make sense of what they're going through in the present. So it's important we consider what has happened to people rather than just focusing on what's wrong with them. So behavior might appear extreme or even abnormal when a history of past adverse events is not taken into account, okay? So you look at someone, you know what I mean, like if we take it back to that glasses example, you know what I mean? So somebody goes into a room and they've got these glasses on, which is the trauma, you know what I mean? It's that way of seeing the world. People can't be trusted. They might kind of find it difficult to engage with people. They might become quite defensive. They might seem quite scared. They might be quite aggressive. It's keeping in mind that because people see the world in this way, it's adaptive. They've been through stuff in the past. The important bit there is if we're not keeping in mind what people have been through in the past, if we just see people's behavior in the present, then it might not make sense. We might be like, I don't understand why this person is so scared. I don't understand why they were aggressive there. But if you keep in mind the glasses, you know what I mean, what have they been through in the past, then it allows us to make sense of that stuff. So people might have understandable difficulties, understanding themselves and others and trusting others, okay? And having a trauma-informed perspective might push us to sort of change our language as well. So, I mean, at this point, you can do what you want with the video. If you want to pause for a minute here and have a think about this language, then you're more than welcome to do that. But it's thinking about, can we look through a trauma lens and reframe how we understand people? And you guys, you might have heard some of this language or even used some of this language before to describe people that you're working with. That's unacceptable behavior. But can we shift that to understandable behavior when we're kind of, once we know what people have been through? Are they avoidant or are they in flight survival mode? You know what I mean? Are they defiant or are they scared? You know what I mean? They're in fight survival mode. Are they aggressive or are they maybe just frightened? Are they attention seeking or is this attachment seeking? Are they trying to communicate a need? Are they withdrawn or are they just being quite cautious? Again, having difficulties trusting people. Are they rude or are they being self-protective? Are they trying to are they maybe scared of people getting close? Are they not engaging or do they just not feel safe yet? It's really important that we start to think about this, this kind of stuff. Okay. Hopefully you're still with me. It's the disadvantages of talking to yourself in a room. Now, stigma. The stigma with BPD is well known. It was a 1988 paper, I think by Lewis Appleby, titled "The Patient's Psychiatrist's Dislike." You know what I mean? I think people with the diagnosis BPD have often been described as the difficult patient, described as manipulative, attention-seeking. There's some papers describing them as nurses' perceptions of them as a destructive whirlwind, or people essentially having such a stigma that it's almost like they've got a red light flashing above their heads as they kind of enter your care. And that's really kind of important to bear in mind, because there's what the stigma does is it can tell a story about the person before you've even met them, because there's such a kind of stigma that actually comes with the person. So BPD carries a significant stigma, and that's particularly at the interface of mental health care. Now, the stigma linked to BPD, I'll talk through some of these things here. So not being seen as a real mental illness. Now that for me it's a bit of a red herring at this point. I think there is lots of debate around what's mental illness and what's this and what's that. For me, it's people in distress that are deserving of our help. Yeah, and I think the story should end there. And if we're not willing to kind of work with people that are distressed, then we need to kind of think about what we're doing. You know what I mean? Being seen as untreatable, I think that's a case of we didn't have the right treatments, we didn't have the right understandings, and certainly now there are evidence-based treatments for BPD. Preconceptions that people with a diagnosis are manipulative, and again, that's something that gets in the way of just that human connection. If we have that preconception, then we go into our interactions with people with suspicion, and we're not our true selves, and we're worried about kind of what we're going to say. And as a result, care isn't experienced as helpful. The stigma is often perpetuated by poor level of knowledge and understanding of the diagnosis and the symptoms. Like I was saying, we need to have an understanding of attachment, we need to have an understanding of trauma, we need to know that this is not just behavior. I really hate that phrase, it kind of irks me, because that's when we're not mentalizing, we're not empathizing with people. There's no just behavior. Sure, it is behavior, but it's behavior with meaning. It makes sense if you understand context. And stigma might be a response to staff feelings of powerlessness. And I've certainly been in that position, you know what I mean, where it can be quite difficult to work with people, to know what to do. You know what I mean? People have got kind of complex needs. They've got like really complex histories. They can find it difficult in relationships. Don't understand themselves, they don't understand other people. And then when we're doing our best and people are not getting better, I think we can quite quickly become defensive and actually start to blame the other person. You know what I mean? We could start to think it's about them, they're untreatable, or there's something wrong with them that is not allowing them to get better, rather than sometimes look at ourselves and maybe things that we could be doing differently. Now, the self-fulfilling prophecy is something that I always talk about. I think it's hugely important. So professionals without hope for people with a diagnosis have been described as a self-fulfilling prophecy, whereby attitudes have an influence on actual outcomes. Now, there's a study from 1968, Rosenthal and Jacobson. They go into a school and they say, right, there's two groups of kids. This group of kids, and actually they're not really going anywhere, you know what I mean? They're going to try their best, but they're not really going to go anywhere. But this group of kids, they're actually really smart, they're brilliant. And there was no statistical variation between the kids at the start of the school year. But because the teachers believed in one group more than they believed in the other, the guys that they believed in actually did better. Again, so there was no statistical variation in their performances before that point, but the teacher's belief in them actually pushed them to do better, to be better. And I think that's really important to emphasize the hope that we need to have for people. Words matter. The personality disorder label is not particularly kind, empathetic, not particularly nice. And I think it's important that we keep that in mind. Now, the voice of those who want the term personality disorder eradicated is loud, and the voice of those insisting that their own personalities are disordered is inaudible. Okay, now there are really quite prominent and powerful movements now, such as PD in the bin, drop the disorder, and the hashtag trauma not PD, that are really campaigning quite relentlessly, and I think justifiably, against this label, which it implies that the difficulties are within the person and not necessarily within what happened to them. Our current insistence on labeling people as disordered is a poor start to any therapeutic relationship. I would absolutely agree with that. If we're thinking of people as disordered rather than thinking of them as people that have experienced difficult stuff and as a result might have difficulties in relationships and difficulties with their emotions, then I don't think we're going to be as good as we otherwise could be. And it's been described as a label that leads to closed minds rather than open arms, and that certainly links to some of the stigma. And I think we might actually look back over time at the term personality disorder and maybe at some point wonder how we ever thought it was okay to label people with it. Now, you might want to take a kind of break at this point because it takes some of this understanding of borderline personality disorder, the experiences that people have had, and consider what issues there might be for people with the diagnosis that become new parents. Now, bear in mind that these are kind of general points, so some specific challenges for new parents. They're not inevitabilities. These are kind of drawn from some literature, specifically around the BPD diagnosis, but remember that people are unique. So these are not kind of givens that these things are going to happen. So I would certainly advise people, don't see a person with BPD. First of all, just see a new parent. If we go in with that diagnostic kind of lens, then we tend to see everything that fits the diagnosis. But if we go in with that humanistic lens, a lot of things will just be understanding in terms of, you're a new parent, I get it, because it's hard. So for a start, being a parent is already incredibly stressful. I liken it to a terrible joy. You know what I mean? I think it's you get so much joy from it. It's beautiful, but it is relentless. It's so tiring. It's so draining. Given the experiences that people have had, people with that BPD diagnosis might find it more stressful than your average person would. And again, we can make sense of that through the experiences that people have had. Now, pregnancy and labour can be incredibly traumatic. So, like, it's worth bearing in mind how smooth has that been for people. Some people get lucky and it's really kind of quick and as painless as possible. I was going to say painless and, like, you know what I mean? Forgive me. I've when I watched my wife give birth, I kind of after it was all through, I phoned my mum to thank her. You know what I mean? I was like, thank you for doing that for me. I really appreciate that. They do not call that labour for nothing. So just consider on a human level, what has that person just been through? If we take a trauma lens on that as well, think when a woman has kind of been through labour and stuff like that, and then just kind of the aftercare and stuff as well, you know what I mean? Really invasive procedures, you know what I mean? And people can be very vulnerable to that, particularly if people might have experienced kind of childhood sexual abuse and stuff like that in the past. We need to keep that in mind, you know what I mean? Has any of that whole process been triggering? It's a huge change, right? It's a huge change. And any huge life change will make any of us more vulnerable in terms of our kind of our mental health. So it's a really tough thing to adapt to. It'll impact on routines that might have been keeping us well before. It'll impact on all of our kind of relationships. I'm thinking particularly about sleep deprivation. You know what I mean? It's something that's almost kind of taken for granted as this is something you will experience, but sleep deprivation, it's used as a torture technique by some kind of militaries. And yeah, it's a very normal part of being a parent. So keep in mind what people are going through. That stuff is really, really tough. Now, there's variations in support available, and I'm thinking there of both the kind of the professional support and just that social network and personal support that people might have. Are people socially isolated, or do they have that help? If they do have that help, what are those relationships like? It's always a chance to kind of for those relationships to become slightly frayed. You know what I mean? When no one's getting a good sleep. And everyone's really, really stressed. And what kind of professional support is available as well? How accessible is it? How consistent is it as well? You know what I mean? Given that people might find it difficult to trust people, what is that like for that person? Worries about an ability to be a good role model. Now, remembering that people might have had difficult attachment relationships in the past, given that your early attachment relationships can kind of create a template for how you see the world and almost can become your normal. So if you have not been understood, then you might find it difficult to kind of understand others. And do you have that sort of good role model in mind that you can apply to your own kind of parenting style? It's certainly not inevitable that these patterns of parenting inevitably repeat. Sometimes they do, but not always. So I think it's important not to kind of just assume that inevitability. But if people don't have those good role models, then they might be needing more support and education around parenting. People might revisit their own childhood by looking at the world through the eyes of their children, and they might remember difficult experiences that they've had as well. So it might be a time of joy, but it might also be a time of reflection. It might be a time of regret. It might be a time of remorse, where people go back there in their heads. So it's just stuff to keep in your mind when you're working with people. Now, attuning to the mental state of the child. Now, a really good example of this is the still face experiment that I'm sure people might have heard of. A really short video, really, really powerful, where you see that back and forth between primary caregiver, whether it's kind of mother, father, or just anyone that's sort of meeting those emotional needs of the child, and they're just kind of getting that understanding of self and others, you know what I mean, through facial expressions, through language, through eye contact. And if people have not been understood, remember, they might find it difficult to understand others. So people might find it difficult to attune to the mental states of their children, to try and get inside their worlds and try and figure out what's going on for them. It's a really extreme example, but one of the most powerful quotes I ever heard was from a parent that was in a mentalization-based treatment group. And they'd said, I've got 5 kids and I've only just realized that they've got feelings. Now, that's really, really powerful. But again, we can take it back to that sense of, if that person has not been understood as a kind of thinking, feeling human being, they don't necessarily take that understanding of others with them. So people look at each other as things rather than thinking, feeling beings. So important to keep that in mind. Again, going to emphasize that it's not an inevitability that people are going to be poor parents as a result of having this diagnosis. It's just not the case whatsoever. We have to keep that person-centered lens. People might have additional needs, absolutely, but parenting can be really good and it can really bring out the best in people sometimes. Another challenge that I think people will probably be familiar with in life, given that there's a lot of judgment everywhere in life, but certainly when you're a new parent, I think we do have fear of being judged, of getting it right. I think at the best of times, when you become a new parent, everyone's got an opinion on how it's best to do this or best to do that. And this might be exacerbated for people by having a psychiatric diagnosis. So there might be fear of being judged anyway in terms of your parenting style. But just by having that diagnosis, are they thinking that there's people around them expecting them to fail, expecting them not to do a good job? And does that actually kind of become a self-fulfilling prophecy through that anxiety? There's also been arguments that because of fears of being judged, that people might actually be reluctant to ask for help because they think that asking for help might be indicating to people that they're not capable or they're not able of doing it. And remember that, like, as professionals, we've sometimes got that power over people, you know what I mean? We've got that power to sort of link up with social work, child protection, stuff like that. And that can very much be in people's minds. So bear that stuff in mind. I know I've already went longer than I wanted to, but I'll try and rattle through this and then leave you guys to think about it. On the flip side of those challenges, the benefits in being a new parent are actually vast as well. You know what I mean? That's my 2 there, you know what I mean? And that's the joy part of the terrible joy. That's a moment where they're not kind of knocking lumps out of each other. So having in raising children is both challenging and rewarding. It can enhance well-being, it can increase positive emotions such as enjoyment, pride, love, can provide a sense of meaning for people in their lives. Teaching and guiding a child can give people a sense of responsibility and achievement that maybe wasn't there for people before. Seeing the world through a child's eyes can kind of give us that joy, you know what I mean? It can give us an enormous kind of sense of wonder about the world again. It can be really, really good for us, and it can be a motivating factor for change. And I've pulled a quote out of this paper that's referenced here. And person says, becoming a parent has improved my health a lot, my mental health a lot. It gets stressful, it really puts a strain on my abilities at times, but in other ways I've watched myself change quite rapidly. It was only a few years ago that I was still cutting myself, and that has stopped. I guess I've found more positive ways to deal with problems. I feel that I now have a purpose, some stability, and a sense of responsibility that I didn't feel that I had before. It's a great example of how parenting can be really good for people rather than something that they're not going to cope with. It can actually go the other way. Now, mentalizing conversations, I've just got this slide and one more after this. Now, mentalizing conversations, I would describe as essentially honest conversations about thoughts and feelings. So mentalizing is essentially the human tendency to make sense of behavior through mental states. So that term just behavior that I was saying I don't like, mentalizing is the antidote to just behavior. There is no just behavior. Behavior always means something, and it means something in the context of what we're thinking, what we're feeling, etc. And then we do things as a result of that. So mentalizing, it's in between kind of mindfulness and empathy, and there's an element of we need to mentalize ourselves and we need to mentalize other people. If I'm mentalizing myself, I just say, what am I thinking? What am I feeling? Where's that coming from? I try and make sense of my own mental state. When I do it with other people, it's a bit more restrained. It's kind of links up with empathy. It's that I wonder what that other person's going through. I wonder what they're thinking. I wonder what they're feeling. I wonder how I can make sense of that. Okay, so there's that self and others that's really important. So if we're having mentalizing conversations with people, for a start, first, we need to see ourselves from the outside, okay? Be aware of how we might be perceived, yeah? So be aware of what is it like to be kind of cared for by me? What is it like to be around me? Be aware of that power dynamic, you know what I mean? Are you going in there with a badge and a uniform? Are you going in there with the power to tell a story about how well this person is or how well they're doing? Have you got access to particular kind of bits of care that they might need? You know what I mean? We've got a lot of power with us, and it's important we keep that in mind. Mentalize yourself, so be aware of what you're thinking and feeling. So it's that kind of case of if you're on an aeroplane that's about to kind of go down or whatever, or there's any difficulties, oxygen masks drops down, you put on your own before you put on someone else's, okay? So we have to be mentalizing ourselves. We have to be aware of our own thoughts and feelings and what's going on before we're helping somebody else understand their own. Always start with empathy when you're talking to someone, okay? Try and get inside their world, see the world as they see it, and show that you genuinely care about it, okay? Whenever we're having difficult conversations, these conversations are always much easier if we've tried to take the person's perspective and we're communicating that we genuinely care about them as well. Focus on a person's mind, not their behavior, okay? Remember, there's no just behavior. Behavior makes sense in terms of mental states. So we want to be curious about kind of what are the thoughts, what are the feelings, what are the beliefs, what are the needs that this behavior is kind of communicating, and trying to make sense of that. We adopt a not knowing stance, okay? Now, I think as professionals, we like to be experts, but we're never experts in another person's experience. So we have to adopt that not knowing stance. Be naive, be kind of, I'm really not sure what's going on for you. I'm trying to make sense of it. Be nosy, be curious. I'm really trying to make sense of what you're thinking, what you're feeling. Can you help me understand that? Now, transparency is incredibly important, particularly given trauma that people might have experienced. People might have difficulty trusting other people. So it's important that we are being transparent so that we can help people essentially build up trust in us. So share what you're thinking and feeling. And you can role model that mentalizing by kind of, oh, this is what I'm thinking just now. This is what I'm feeling. I'm a bit worried about this. Just be really human and be really real with people. Now, a common thing for anyone working with people with a BPD diagnosis is being almost scared to have difficult conversations, or being, I think it's important that I say this to this person, but I'm worried about how they're going to take it. I'm worried about upsetting them. But I think it's important that we do have these difficult conversations. But if you're worried about saying something, if you're worried about upsetting somebody, for an example, I would say that. I would front load that. I would say, look, I think it's important we have this conversation, but I'm worried about it upsetting you. So I want you to know I'm not trying to upset you by saying this, but I do think it's something that is important that we explore. And essentially what you've done there is you've kind of apologized before you've potentially upset someone. And if you're being transparent, if you're being really genuine with that, then people will generally kind of go along with you. You know what I mean? They'll be willing to explore that stuff. But we should never leave stuff unsaid. We shouldn't leave the things unsaid that we feel are important because we're scared of having these conversations. If you have a conversation in a mentalizing way, you'll get there. We want to encourage curiosity in self and others, okay? And that includes, sorry, I've just skipped that ahead there. And that includes a curiosity in the child. You know what I mean? You want to say, like, when they're crying, when they're doing this, when they're doing that, what do you think is kind of going on for them? And you're encouraging that attunement, you know what I mean, to making sense of thoughts, feelings, and how they impact on behavior. And we want to move assumptions to inferences instead of kind of very fixed, kind of black and white thinking around what people might be thinking and feeling. We're able to introduce some of that grey area. I think we can quickly misunderstand people. We can say, oh, this person didn't phone me at that time, so obviously they hate me or they don't like me. And then just introducing a bit of doubt. Well, I wonder if there was maybe something else going on for them. I wonder if there's different ways of looking at this. So we're introducing a bit of grey area, a bit of doubt, and we're willing to kind of tolerate different perspectives. And ultimately, if we don't understand what a person is communicating or what they're going through, say so, but just show a willingness to try and understand. You know what I mean? Stick with people, persist, say, I'm still not getting it, but I'm really wanting to understand. I think it's really important that kind of I understand you so that I can kind of help you as best I can, and clarify that understanding as you go. Say, right, so okay, this is my understanding as I've got just now. Is that right? You know what I mean? Check that out with people, and that's really important. And I apologize at this point, it's went on longer than I thought. It's always difficult for me to cut this stuff down because I think it's also important. So it's my final slide, and this should be reasonably quick. So the things that people ultimately benefit from us are simple: having access to care and practitioners who are available. And by available, I don't just mean physically present, I mean actually emotionally available for people as well. Having a consistent professional they can trust. Now, relationships are so important when we're working with people that have experienced trauma, difficulties in attachments, and people with a BPD diagnosis. So consistency is important. Now, I know that obviously because people are engaged with a health service, we can't always manage that consistency 100%, but at the very least, we need to be mindful of it. If there is ever anyone that's kind of stepping in to cover for someone, or there's ever a transition to another professional, you need to try and preempt that as far as possible. Try and talk about that transition. Try and manage that transition. Can you get somebody to meet somebody else before they're immediately handed over? Because for me, trust is not something that we should expect. It's something that we earn. And people don't have relationships with a health service. They have relationships with human beings. So keep that in mind when we're organizing care for people. People want to be treated like a person rather than a diagnosis. People don't want stigma. They don't want to be judged. They want these mentalizing conversations. They want to have a focus on their minds, focus on their underlying distress rather than just their behavior. They want emotional and practical support. They want to share in decision making. They want to be that collaborator rather than that recipient of care. Want to be offered hope by staff that believe that they can recover, and remember that self-fulfilling prophecy. Staff who have a space to reflect. Look, working with people that have had complex histories is complicated at times. So it's important that we have an opportunity to attend clinical supervision or have that that reflective space where we can kind of really talk about our work. And I've heard a sort of clinical supervision described as that difference between eagles and frogs. You know what I mean? So are you getting supervision, and are you the eagle? Are you able to kind of sort of come out of it? Are you able to rise up high, take a perspective, see the context and make sense of it? Or are you a frog that is kind of slowly boiling and unaware of it? So certainly supervision at a space to reflect is really important. And humanity, you know what I mean, just being human. And there's a quote again from one of those papers saying that it's that they show a lot of empathy, comprehension, a lot of humanity, but at the same time, they're very professional. I don't know how they do it. And another quote saying, you sense a human connection. At the same time, what I've received is, I understand you, I have some tools to help you, and we'll work on it. And for me, the most important things that people have said to me at the end of kind of care have been that I always felt like you cared. And my current favorite thing that anyone ever said to me was that I feel like I was talking to you and not the NHS. And I think that's where I'll leave you, because that's the most important stuff that we do for people. Now, to learn more, there will be further resources and references, and those are my contact details if you need. That's the first page of references that you can pause at if you want, and second page of references that you can pause at if you want. Now, thank you, and I'm sorry that went on longer than I thought it would. All the best, and I hope it was useful.